Good afternoon, ladies and gentlemen. Thank you very much for this warm reception, and I'm very happy that I can take the floor in this distinguished group, in front of this distinguished group of people who devote their time and effort to topics related to long-term care. I have learned a lot from the previous presentations today, not only from the professional point of view, but also from the purely humane point of view when I think about these things and about people who are uh, my loved ones. So there is this humane aspect that emerged in all the previous presentations, and I think that it corresponds to the topic of my presentation. And I would like to take a more system-oriented look. The, the initial title was the individual at the heart of the long-term care system, in order to emphasize the empathy that should accompany us whenever we think about providing care at the lowest level, but also when we think about designing the system. Because sometimes it's difficult to recognize, to notice and recognize the individual with their needs and experiences when you look at this issue from the top level of the system. So the attempts to find a model where all services and institutions are tailored to the needs of an individual, where it's relevant to their needs. These attempts have been made for many decades under various names: user-centered approach, person-centered approach, person-oriented approach. But the core or the main idea was similar. So it was about focusing on the final recipient of care, to focus on their satisfaction and their decision-making capabilities. And over the decades, both in practice and in theory, in research, the concept evolved and it developed. Various new layers were added to this model, and one of the previous speakers presented those diagrams showing how many factors are involved in this person-centered approach. And if we review literature today, we can see how many papers are being published, both theoretical and practical, related to the system level or the level of specific institutions. We can find papers, interesting papers over the past 2 or 3 years on how to design a care facility or care home, for example, for elderly people, but also taking into account this person-centered approach. And it is worth noting that initially this concept was developed and based on medical sciences and around medical sciences, but an important thing is how to transfer this philosophy into other contexts, non-medical contexts. A large part of care is provided outside of the medical healthcare system, but also outside the formal system. In Poland, we have a major share of informal or semi-formal care provided. So we could think about home care and care provided by family members or with participation of family members. So this is one of things to consider. there is a number of dimensions of this approach that should be put into practice. One very important thing is focusing on the quality of the care process. Quality from the point of view of the final beneficiary or recipient of care. It's not about formal components, but it is the actual quality of care. And the issue of well-being of the patient, the orientation on the right to decide about oneself, autonomy. This discussion about choice and independence often appears with regard to discussion about providing care to people with disabilities. But sometimes it becomes problematic when we talk about highly dependent people who are unable to make their own choices or express their satisfaction. But we've heard in the previous presentations today, we are able to much better communicate with people with neurodegenerative diseases. And we also have the components of agency and impact that we can put into practice.
Empowerment, intimacy, issues related to dignity, because in the original approach there was a lot of stress put on consumer choice for the end user to use and to decide, but you should not stop at that. There are other important aspects apart from freedom of choice related to intimacy, dignity of the care process. What's important is the coordination and comprehensive nature and the broad range of various forms of care you could use. And something more novel, issues related to the way of designing specific institutions and services, and it's important for it to be based on participation, including the end users. When you think about the system, for example, developing regional and national programs, it's important for the representatives of the sector, people representing the self-advocacy or groups, to participate in the co-designing these solutions, for it not to be forced on them. And the last important issue is orientation on maintaining activity. Sometimes these can be very simple tools, like in the case of my grandma, like a walking bar was fundamental. So walking aid helped her move. This walker, walking frame, helped her be independent. So developing these solutions, it's important where possible to maintain or raise the activity level. There's an issue that I think it's worth raising against the backdrop of this concept: the role of caregivers or carers. The one hand, you want this end user to be at the center, but in the whole system we have many stakeholders, including the loved ones, the members of the family. Sometimes it's not stressed enough in literature and in practice, but in my opinion, if we're starting from this humanistic, ideal, person-centered concept for the person to be at the center, at the heart, also the carers should be seen as people as much as possible. They should not be perceived as the cogs in the machine performing the role. They are not, their subjective rights are not respected or even noticed. So, starting from this philosophy, the subjectivity activity of the care, including family, informal carer, is also important. Because undervalued, unnoticed, unsupported care increases the risk of neglect, of mistakes in care, which will ultimately lower the quality of the care for the end user. But also to follow this moral imperative to see the carer as a person. I'm paying attention to that, including our recent experience in public policy, like the manipulation of the support allowance starting in 2024. That was a game changer. And the financial support system based on disability and for carers, and they shifted the burden, or they shifted the stress towards direct support for the person in need of support. I mean, from what we had before this allowance addressed to carers. I mean, you can agree or disagree whether the direction of change was right. I mean, people differ here, but it was a bit lacking. What remains a challenge from the point of view of public policy is noticing the carers, because now, when the allowance is not tied to caregivers, they are even more invisible to the system. And some of the members of the community of carers I'm in touch on an everyday basis perceive this allowance as a sort of a threat for seeing and appreciating their role in supporting the loved one in need of support. We should also look at new contexts. I mean, the first context is what we discussed today, the resilience of the system, its resistance to various stresses like the pandemic. There were many signals showing that, for example, I mean, even in good faith, to protect people from infection, from complications of coronavirus infection, people would create solutions limiting their subjective rights in various facilities, as shown by the report by the Ombudsman. I'm not saying this to place the blame on anyone, but there is some tension sometimes between providing safety and respecting the rights of the individual that I mentioned before. So the tension is growing in crisis situations like the COVID-19 pandemic. It's quite possible that like the crisis we are suffering from now related to the flood. So it's worth noting, technological changes, on the one hand, they are an opportunity to customize care, but on the other hand, they might carry some risks from the point of view of this relational and humanistic aspects of care, and intersectional theme in social sciences. We mentioned the intersectional perspective. We look at certain groups from the point of view of overlapping features and identities. When we research disability, we look at the situation of women with disabilities or people with disabilities with some additional features that can make them more vulnerable to all kinds of discrimination. The same goes for care. If you want the care to be personalized, customized, tailor-made, and providing a holistic approach to human experience and human identity, we need to see the recipient of care as a whole. See their various experience, but also various features like their ethnic origin, religious identity, sexual orientation, etc. Because sometimes taking these aspects into account can help us better customize the service to these individual needs. I see one more dilemma resulting from the philosophy itself. On the one hand, we want the system to be as customized and tailor-made as possible. On the other hand, there's this feeling that sometimes what's lacking are standards. Standards could bolster the subjectivity of the person in the system. On the one hand, we have standardization. This is something that can be averaged out. And on the other hand, there's the need of individual approach, and we do find the Goldilocks solution, the golden mean here. And the second challenge from the point of view of managing the systems related to the share of responsibility. We know that long-term care in Poland, but as we could see also in France, in other countries, is managed over many levels, and many tasks are delegated to public or private entities. When the responsibility is fragmented, a question arises how to provide the optimal responsibility not only for provision of the service based on certain legal standards, but also to be responsible for the softer aspects, which are clearly visible in the approach of person-centered care. I mean, thinking against the backdrop of what's happening in public policy now, we have at least two conceptual work centers in the public administration. On the one hand, there's a special interdepartmental task force on long-term care. It's been operating since spring this year and before the summer. And I'm sure it was working even more dynamic. There's the team on the reform of social aid. It will obviously cover only a part of the care system, more related to social care, which is regulated by the social care system. Anyway, some changes can be developed in these groups, in these teams. I somehow participate in their work, and I'm just pondering what should be the regulatory approach or the regulatory horizon to orient these efforts related to various components of the system. And these teams, especially the team on social aid, they're very broad. There's a varied representation there. What could be the common ground here, the common foundation? And around this idea of person at the heart, and using the legacy of practice and science and research, I think we should look for this horizon there. This would be my approach anyway. This is how I imagine that. As I mentioned, discussing the previous slides, I mentioned various parameters of the system. Anyway, it would be great after a year or some more time, once these teams arrive at certain conclusion, we could say, okay, that the result of the work, conceptual work, and their implementation, we have managed, for example, to raise the level of implementing the various values we mentioned before, like related to the fact that the user will be more subjectively treated, their dignity will be better respected, etc. For sure, there are a number of guidelines we should follow, in my opinion, for the public policy in care to serve the person and be customized. We need to monitor and implement these standards of quality broadly understood in care. It's not an issue in the medical sector, but in social care, social aid system, there are various issues related to that. Not everything is properly regulated. And the issue is that the insufficient stress on the quality may be related to the fact that many municipalities, many users are facing the challenge of providing the availability of the care. It is at this stage that the issue arises, but it's worth thinking about the quality aspect. The second aspect, reasonably understood deinstitutionalization. Sure that the word generates all kinds of emotions, even here, not always positive. What I mean here is not deinstitutionalization understood as departing from institutions which are 24/7. We cannot afford that. This would not be the right way to go. But on the one hand, to extend these forms of support within the community, and on the other hand, for people who remain in facilities, in nursing facilities and social care homes and other 24/7 facilities, to make it more community-based, for them to meet the requirements related to autonomy, contact with the outside environment. I know that in many facilities it's happening already, but maybe we could support it additionally with certain public mechanisms, monitoring a broad range of rights of people using care in various settings, partly inspired by the reports by the Ombudsman, even though they focused on 24/7 whole day facilities, but I think that the risk related to the patients are also true outside of the facilities and 24/7 institutions.
Also, strengthening the competences of care providers in the context of communication with the users, and also ensuring support for caregivers. This is both in terms of educational and technical support, but also psychological support or respite support for these people. And also something that I have mentioned in one of the slides, that is ensuring the resilience of the system with regard to various shocks or processes that take place and that we have to adapt to. So those would be the main directions of ideas, directions that the public policy should be heading in. And I'm also interested in your feedback, your opinion on this concept of person-centered care and what it could mean in the light of your experiences or the experiences of your institutions. I'm looking at this model in such a way that it can be seen on various levels, both at the level of national policies and at the level of very specific institutions, or even a specific care relationship and the way of communicating and building the relationship between the carer and the patient or recipient of care. So I think it would be all from myself. Professor Błędowski told me that I would be the last speaker, so I tried to make it brief, but if there are any questions right now or during the informal meetings and discussions, I'll be very much willing to talk about that in more specific terms. I just wanted to make an outline here. So once again, thank you very much. Thank you very much. And it seems to me that your presentation was sort of a bracket combining everything today, but it will be also a good starting point for tomorrow when we will discuss the topics and things that appeared in your presentation. If someone has a question to deepen the thoughts or considerations from the presentation, the floor is open for questions. But you raised my interest because on the one hand, looking at macro assumptions, it appears to me that we can feel the directions in which long-term care, at least in Poland, is transforming. On the other hand, we're talking about the assumptions at the early part, during the early part of the presentation, there was the issue of participation of recipients of care in decision making and designing the solutions. And this is very important with regard to person-centered care. But from your scientific experience, from the perspective of the ministry, do you see such cases where the patients or recipients, beneficiaries of care, were really involved in designing long-term care? Or when you are talking about that, do you have any good practices or guidelines for us, for practitioners, to respect this principle of participation in decision making, not only right here, right now, but also about the future shape of the long-term care system? If you could take a moment to answer the question. It is a difficult question to a certain extent, because in Poland, the communities that are affected by this directly, so people who are in need of care and their families, this is a rather dispersed and unorganized group, not as organized at least as in some other countries like in Ireland or the UK, where Cares UK or similar groups and associations have developed a certain subjectivity and certain role in influencing public policy. In Poland, it is quite different. The movement that I was associated with, the movement of excluded caregivers, it was more of a fighting movement to fight for dignity, to fight for higher social security benefits. But if we look at it from in a longer time frame, I've been working in this area for 10 or 15 years. You have more experience in many cases, but looking at these self-organizations of caregivers, I can see that there has been a certain positive evolution. On the one hand, there is more organizations, there are bigger networks, and there are sort of umbrella initiatives emerging, a combination of several different initiatives with a certain flow or exchange of knowledge. And there are also initiatives like our ombudsman group, Caregivers Ombudsman. There is an expert group consisting of people who are caregivers or used to be caregivers themselves, and they have a more holistic approach and considerations of various proposals and consulting these issues. So perhaps this process will continue towards more professional organization of social stakeholders and people involved, and also stakeholders from the informal sector like families, caregivers, former caregivers, and wherever possible, people in need of care. So together we should build bridges towards the representatives of the formal sector and various organizations. And there have been various attempts with some of the associations or centers providing care services. There are attempts to build a broader network of people doing something, organizing something locally, but sometimes also fighting or lobbying for something on a higher level. So it would be very useful also in the context of public policy. So we need to create a certain climate so that ministries or state bodies that are responsible for that area, that they could refer to these expectations on the part of the social sector, the general public, because this will make it easier for certain ideas to become part of the mainstream or to be used in political discussions. So I would like to encourage you to be active in sending in your reports, sending in your recommendations and issues to the authorities.